Good
Let me.
evening, sir.
Good evening.
I'm Rajashreya from Dehradun.
Good evening, madam.
Good evening, ma'am. Welcome.
Actually, I had an emergency, medical emergency in the family, so I'm in the car, unfortunately.
Okay.
Uh,
Not,
so I had told Dr. Shobit, but he said that I could just at least join in and at least be at the beginning of the topic. So I'm not really sure if I can continue throughout. So it's up to you.
okay. No issues, ma'am.
So
No
all
issue,
right.
no
You
issue.
are available. Thank you.
Someone in the family is not well.
Dr.
So that
Alim can be
is
the host, no problem.
okay.
Thank you.
Yeah. So I think I'll start the slide share and start the meeting. Yeah. I hope it is visible.
Yes, full screen mode.
Okay, so we are all set now. My warm welcome to all of you. This is the 213th edition of Thursday Musings. Everyone will be on the mute mode. Panelists will be able to unmute themselves. Dr. Shobhit is joining us as a co-moderator today. The meeting is being recorded and will be put on YouTube for later on. The questions are invited in the chat box. And today's topic is hyperprolactinemia and how to manage it. And now I'm handing over the session to the chairman of this program, Professor Dr. Tofan Pati, sir. Sir, over to you.
Thank you, Dr. Alim. Welcome this evening to episode of Thursday Musings. Next slide, please. I have a formal duty to introduce Dr. Amrit Patosi and Dr. Alim Siddiqui, and also Dr. Vishal Chabra as moderators. And usually, to save time, we skip over the elaborate introduction, but all three of them are vibrant members of IPS. This episode, we have a moderator, Dr. Sobit Garg, who is joining us this evening. He is Professor, Department of Psychiatry, Sri Guru Ram Rai Institute of Medical and Health Sciences. He is in charge of neuromodulation, SGRR M&HS, Chairman, Research Review Committee of SGRR M&HS, Associate Editor, Archives of Biological Psychiatry, President-elect Himalayan Psychiatric Society, Chairperson, Neuromodulation Committee of Indian Psychiatric Society, Convener, Social Media Subcommittee of SARC, Co-Chair, IPS Suicide Helpline, Past Secretary, Himalayan Psychiatric Society, Past Convener, Social Media Cell, Indian Psychiatric Society 2020, Executive Council Member, IAPP, UP and UK, Member, Editorial Board of IJPM, Reviewer in various national and international journals. Areas of interest, bipolar disorders, brain stimulation, research and publications. He has got 70 publications to his credit and 18 book chapters. Welcome, Dr. Subit, to our fold.
Thank you, sir.
And I have the pleasure to introduce our esteemed chairpersons this evening, Dr. Beda N. Settagiri, Professor, Department of Psychiatry, East Point College of Medical Sciences and Research Center, Bangalore. Published many research papers and presented oral papers and symposia in various state, national, and international conferences. Areas of interest, sexual medicine, consultant liaison, child psychiatry, women's mental health, and psychopharmacology. Other contributions, listing authors of the book MCQs in Psychiatry, Psychology, and Psychiatric Sociology, who has had already four editions, and Gender Trauma by IPS South Zone. Conducted IPS cases state level UG MCQ prize examination for UG or interns in psychiatry for the year 2 years. Has contributed in the making of Monodarshika calendar in Kannada language to the generate mental health awareness among rural population. Positions held in organizations. EC member of IPS Karnataka chapter for 3 years. Currently serving as a convener of IPS PG Academic Subcommittee and Assistant Editor of Indian Journal of Psychological Medicine, IJPM, and Reviewer of for the Journal of Psychiatry Spectrum and Journal of Sexual Medicine. Welcome, Dr. Beda.
Sir, thank you so much, Tufan Pati sir, for such a kind introduction. Thank you.
And Dr. Shreya Sharma, consultant endocrinologist, Max Super Specialty Hospital, Dehradun, is the other chairperson this evening. Welcome, Dr. Shreya. She is MD NDM in endocrinology from IIMS New Delhi, fellowship in pediatric endocrinology, BJ Wadiam Hospital, Mumbai. Awards and publications, recipient of ESI, the Young Scholar Award, TYESR, runner-up 2022-23. Published 16 scientific articles in peer-reviewed national and international journals and 2 book chapters. Life member of Endocrine Society of India and Indian Society of Pediatric and Adolescent Endocrinology. Research interest, pediatric endocrinology, reproductive endocrinology. Welcome, Dr. Shreya, ma'am. And with this, hand over the meeting to the chairpersons, Dr. Beda and Dr. Shreya. One will introduce Dr. Jagjot Singh, the speaker today evening. I welcome you.
Yes, sir.
And the other will introduce the topic.
Yes.
Welcome. Now the meeting belongs to the chairpersons. Please carry on.
Can I introduce the chairperson, the speaker, sir, for the evening?
Please do.
Yeah. It's a privilege to introduce Dr. Jagjot Singh for today's Thursday musings. Sir is a consultant psychiatrist with an experience of 8+ years in the field of psychiatry. He did his MBBS from GMC Patiala and MD Psychiatry from DMC Ludhiana. He is currently working as a consultant psychiatrist in the Department of Mental Health and Behavioral Sciences, Fortis Hospital, Ludhiana. He is also the founding director of JJ Clinics. He has done various national and international presentations on topics such as economic burden of depression, effect of demonetization on mental health and metabolic syndrome. His areas of interest include liaison psychiatry, perinatal psychiatry, and movement disorders. I welcome you, sir.
Thank you, ma'am. Thank you so much.
Yeah. Maybe.
So, shall we start the presentation, ma'am?
I think, yeah, Dr. Shreya was in
Sure.
so
So I think we can proceed, sir. She is
Yeah.
into some emergency.
Right. So, just take away please. Good evening, everyone. Today's topic is hyperprolactinemia. We'll discuss about the hormone prolactin. We'll discuss what do we as psychiatrists need to know about prolactin. If there is hyperprolactinemia, there's a patient with hyperprolactinemia, how should we proceed, manage? In cases which is drug-induced, also if we find out that it was not drug-induced and there is a pathology or there is an etiology that has caused a raised level of prolactin, when should we be worried about the raised level of prolactin? What should be the dose range that we should know that this is normal, this is abnormal, this is where we step in, this is where we can still wait. And if at all there has to be a management or treatment modality, what should be the treatment in line? Since we have an endocrinologist in the meeting, so I have tried to cover certain aspects which involve cases where it is not drug-induced. So hyperprolactinemia in psychiatry. Hyperprolactinemia and psychiatric disorders, there are primarily 2 scenarios that we are going to face. One is going to be antipsychotic-induced hyperprolactinemia, which is often asymptomatic. The second is going to be psychiatric disorders arising from the medical treatment of hyperprolactinemia, which we'll discuss verbally. It is important that psychiatrists and endocrinologists approach together the management of hyperprolactinemia associated with psychiatric disorders in different forms in order to avoid serious and devastating complications for the patient. Now, talking about drug-induced hyperprolactinemia, it is the most frequent cause of non-physiological hyperprolactinemia, and the degree of hyperprolactinemia in most cases is dose-dependent. How frequent is drug-induced? Well, one study in Scotland revealed that in 45.9% of the cases, it's the drug-induced hyperprolactinemia. But should we be worried about it? And if yes, to what extent? So let's look at prolactin. Prolactin is a monomer. It's 23 kilodalton. It's the 85% biologically active hormone. Its function is to induce lactation. Then there's an entity called big prolactin, which is 50 kilodalton. It's a dimer. Then there's something called big prolactin. Its size is more than 150 kilodalton. It's not just prolactin. In simple terms, it is the monomeric form combined with IgG autoantibodies. So it forms a huge size. It has minimal or no activity. And because of the big size and because of its presence, certain times when we go and test, it can come out to be a false positive in terms of prolactin being raised, but patient clinically having no symptoms yet. Prolactin is higher in females in general. Dopamine is the main regulator of prolactin through primarily D2 receptors of all the receptors involved in dopamine pathway. Hyperprolactinemia, it is diagnosed when prolactin levels are higher than 25 nanograms per ml, which is in females, and if it is higher than 20 nanograms per ml in males. So what is the most common presentation if you're looking at someone who is symptomatic? It will be hypogonadotrophic, hypogonadism, and galactorrhea. It's the most characteristic sign and symptom of prolactin excess. Now, a brief look at its regulation. Prolactin is secreted from lactotrophs, that is from the anterior pituitary, primarily inhibited or regulated by dopamine. Hence, we need to know, since in psychosis or in places where we use dopamine antagonists, the level of prolactin can rise. It is released from hypothalamic dopaminergic neurons into the hypophyseal portal blood. Dopamine is inhibitory to prolactin secretion. So from the first two slides, all I want you guys to remember, the basic thing is dopamine inhibits the prolactin secretion. If something inhibits the dopamine, prolactin will rise. Now, in the suckling stimulus, it inhibits the hypothalamic dopamine release, allowing elevated prolactin levels to be achieved, which is a must for lactation. Other stimuli include sex, sleep, and orgasm. Inhibitory factors include stress and cannabinoids. Well, this is a basic variation in the serum prolactin levels over 24 hours in healthy men and women. In the graph, you can see when the lights are off and both are sleeping, in the females, there is a slightly higher value than the male, and it increases even more in the REM part of the sleep. Now, this brings me to the first most crucial slide of the presentation. What are the major causes of hyperprolactinemia? Once we know the major causes, then and only then we can decide whether we need to treat. And if we have to treat, if we have, as a psychiatrist, we need to venture into it, then what should be done? What should be the course of action? It's very important to rule out normal physiological causes when you see the patient having raised prolactin. If there is nothing physiological and you are thinking of something pathological, some disease entity, it's important to remember certain conditions which might be responsible for the raised prolactin level. Once they are excluded, we come to the pharmacological, which is probably going to be our domain. Having said that, we have to remember that there are other pharmacological agents which are non-psychotropics, or if I may say, antihypertensives, certain opioids, certain anti-emetic agents, certain anti-epileptic agents which can cause raised hyperprolactinemia or raised level of prolactin, which we should always keep in mind, so that if there comes a time that we would have to change a treatment, we should actually get to know that whether it was the cause or not. So let's look at what can physiologically increase prolactin. Ovulation can increase prolactin. Pregnancy can raise prolactin. If you have a young female patient, comes with a report of raised prolactin, if you seem appropriate, a urine for pregnancy test can be ordered. If the female is at the breastfeeding time, if the patient is under a lot of stress, remember even a stressful venipuncture can lead to raised level of prolactin. If exercise has been there, let's say for the sample, the subject had to climb 4 stories or had to climb, or the patient just came running from somewhere and was or exercising, or even had just had sexual intercourse before giving the sample, can lead to a falsely raised prolactin. Nipple stimulation during breastfeeding or otherwise can lead to raised level or a chest wall injury, which is going to be a rare phenomenon. Pathological. Now, we've heard of it, prolactin secreting pituitary adenoma. We'll talk about it, about the microadenomas and the macroadenomas. Stalk effect from the cellular or paracellular lesions. We have to remember that if there is renal failure or hepatic failure, it can lead to the raised levels of prolactin. So if you see a patient and you see the report, prolactin levels are high, and the patient is asking you, whether doc, is it your medication that is causing me? Before jumping to any conclusion, rule out physiological causes, ask for certain blood tests, rule out renal failure, rule out hepatic failure. If it is there, if the patient has, let's say, chronic renal failure, patient is a case of CLD, or if the patient has recently had hepatitis, that can also amount to hyperprolactinemia. If the female has come to you with symptoms or clinical presentation of, let's say, hirsutism, weight gain, dysmenorrhea, or amenorrhea, get an ultrasound, rule out PCOS. That can also be one of the causes of raised prolactin. Seizures. Well, in epilepsy, it can happen. Anti-epileptic drugs, which we'll cover in the drugs, part pharmacological part, phenytoin can notoriously increase it. Especially when a seizure has just taken place, if you send a sample of prolactin, it may come raised, which can also tell us in certain cases of dissociative disorders that the episode that just occurred was actually a seizure. Although it will not be very specific. Pharmacological, we all know that our antipsychotics are known to cause. First generation antipsychotics have more propensity to cause hyperprolactinemia. Second generation antipsychotics are less likely to cause hyperprolactinemia. Two names I want you guys to remember is, one is risperidone and second is amisulpride. They may come under second generation, but they raise prolactin like the first generation. So even if the levels are markedly high, the patient is on risperidone and you hold it or you decrease it and you see a fall in the prolactin levels, you do get a hint that this very molecule, risperidone, paliperidone, or amisulpride, can cause it. Antiemetic agents such as metoclopramide, widely known as Perinom, domperidone, considered in various PPI combinations such as DSR, can lead to hyperprolactinemia. Antihypertensives, not the recent ones, rizopine, L-methyl dopa, certain drugs can cause increase in the prolactin levels. Now, when we come to our antipsychotics, which are the antipsychotics we can consider safer, which have a tendency to cause but very less likely, and which are notorious to cause hyperprolactinemia? It was seen that no significant prolactin levels were raised while aripiprazole, clozapine, or ziprasidone was used. Out of the whole slide, if I want you guys, one thing to remember, it will be aripiprazole. If you want to be legally safe, if you want the patient to, if you want the levels of prolactin to come down, think of aripiprazole as an adjuvant. If you want that, you don't want the primary drug to be there and you basically can't help but switch the medication to some other antipsychotic, can think of aripiprazole. Yes, definitely clozapine will be another option. and ziprasidone will be another option. Now, in less than 25% of the patient, with the typicals, it was pimozide and loxapine, and in the atypicals, it was olanzapine and quetiapine. On the safe side, it can be said that the pines, such as quetiapine, olanzapine, clozapine, and aripiprazole, these are the molecules which are least likely to cause hyperprolactinemia. In fact, aripiprazole, there are only and only few case studies, which is not an evidence enough. Not to forget ziprasidone, which is used very less, but is quite an effective molecule. Now let's look at molecules which are responsible in more than 50% of the patients. In the first generation, well, we can think of haloperidol. You can say that the degree of dopamine receptor occupancy will dictate the level of hyperprolactinemia that is seen in these patients. Chlorpromazine would be the second agent. Well, all of the first generation can cause hyperprolactinemia, and they usually cause it more than the second generation. Amongst the second generation, two drugs which I want you guys to remember always is risperidone and amisulpiride. Well, they're notorious to cause raised in the levels of prolactin comparable to first generation. And to some extent, there might be certain cases where you could see the levels of prolactin above 100, which is rarely seen with molecules or pharmacological agents. And the culprit would be risperidone or amisulpiride in those cases. Out of the other agents, there is this molecule written sulpiride. I would want you to remember that levosulpiride in the PPI combinations with the L component is another agent that can lead, because that's an antipsychotic with certain prokinetic properties that can lead to raised prolactin. So when you look at the prescription or when you look at the patient's treatment being going on from some other clinician, rule out whether they are on those two antihypertensives, antiepileptics, certain agents, certain antiemetic agents, phenytoin, and even levosulpiride, which can be from our own prescription as well. Now, frequency of raised prolactin with other medications. Primarily, we are going to talk about antidepressants. The baseline that should, or takeaway message with the antidepressants should be very, very rarely, it's not that common that they lead to significant or symptomatic hyperprolactinemia. If at all, there are certain agents which you should always remember amongst antidepressants. I would like you to remember two agents. One is clomipramine, which is more than 50% chances. And second, out of the SSRIs would be fluoxetine. In general, TCAs, amitriptyline, amoxapine, clomipramine, with the various names as written, can lead to hyperprolactinemia. Most of all, clomipramine. MAO inhibitors, yes, comparable with clomipramine. And antiemetics, metoclopramide, domperidone, which comes under the name of Perinom and Domstar. Antihypertensives, methyldopa, rezapine, and another agent, verapamil. Now, what are the symptoms? And why should we look at the symptoms? Whenever we talk about hyperprolactinemia, if the patient comes with a report or you've ordered a test for checking the levels of prolactin, you have to remember that you are going to do something about it only if the patient is symptomatic. If you're thinking of certain drug-induced hyperprolactinemia, patient being symptomatic should be the utmost criteria for you to intervene and do something about it. Otherwise, sometimes a patient gets scared that they get the report, they see the levels are raised, they Google it, they find out it's a tumor, there's a brain tumor which can cause, and either they come and sue you or they sometimes go to another doctor. Doctor, is it a possibility? And the other doctor cannot deny that. Hence, sometimes we are in a fix. So there are certain strategies that you can do before starting antipsychotic. There are certain guidelines in the West which say that do get a level of prolactin before you start it, ruling out physiological causes and certain pathological causes. If you feel that it's not easy to get prolactin levels every time you see a psychotic patient, or you want to start antipsychotic, because that happens like a lot of times in a day that you're prescribing, just take a brief history of sexual functioning prior to starting the treatment with an agent that is an obvious cause, a pharmacological cause of hyperprolactinemia. Preferably write it down on your prescription that these were the levels of sexual functioning prior to the treatment. In those cases, you can skip the testing part. If you can get it tested before starting, well, definitely you're legally safe. Let's look at the clinical presentation in women, especially premenopausal women. You have to remember that there's a relation of estrogen and prolactin. So high estrogen, there's a chances of the prolactin being higher. Hence, we'd say premenopausal women will have more chances of developing this rather than postmenopausal women. So let's see, marked excess prolactin, that is 100 microgram per liter, is commonly associated with hypogonadism. The female will come with a complaint of galactorrhea. She might complain of missing her periods, or sometimes missing her periods, or complete amenorrhea. She might come with a complaint of hirsutism, facial hair, acne, and vaginal dryness. Now, when you have such symptoms first, and the levels of prolactin are raised more than 100, this is markedly increased prolactin level. We'll discuss how to manage these. In moderately excess prolactin levels, that is around 50 to 75, it is usually associated with oligomenorrhea. In mild prolactin excess, that is 31 to 50, it's associated with short luteal phase, decreased libido, and infertility. One has to remember that the levels do not always correlate with the symptomatology. Patient can have mildly raised prolactin levels, but can have symptoms of galactorrhea. Patient can have around 70, the level of prolactin around 70, and you can have, on the MRI, you get to know that there is a adenoma, and you were thinking that it should have gone more than 100 or 200 perhaps. No, that doesn't really happen. Increased body weight may be another associated symptom, especially when there's a case of prolactin secreting pituitary tumor. Osteopenia is present mainly in people with associated hypogonadism. So osteoporosis, osteopenia, bone loss is something which you should remember that will happen over the span of years. So if you have someone on treatment on any agent which can cause and is showing symptoms of hyperprolactinemia, remember that there is osteoporosis going on at the same time as well, not just galactorrhea or hirsutism or amenorrhea. So in the long term, you have to take care of giving them calcium supplementation, getting their vitamin D levels checked, and if at all required, bisphosphonates and various modalities to take care of preventing or slowing the osteoporosis or osteopenia. In men, if they have hyperprolactinemia, they will tell that the sexual desire has gone down. Doc, is it because of the medication? Or perhaps I don't have the erection anymore. Some patients even report that the quantity has come down, which could be subjective, but there is decreased sperm production. Definitely infertility is one of the symptoms present in both the genders. Gynecomastia is one symptom which is quite annoying, and sometimes the parents feel ashamed discussing. It's our duty to, every time when the patient visits our OPD, when we do the basic MSc, to also look for physical symptoms such as gynecomastia, which can happen. Rarely galactorrhea in men. Impotence is unresponsive to testosterone treatment and is associated with decreased muscle mass, body hair, and osteoporosis. This could be debatable, but some of the studies do suggest this. Diagnostic approach. Blood sampling. Well, the current guidelines state that serum prolactin can be drawn at any time. Earlier, it was preferably in the morning. Exercise and nipple stimulation should be avoided at least 30 minutes prior to testing. Typically, normal prolactin levels are less than 20 in male and less than 25 in females. This is the ballpark figure I want you guys to remember. That is normally less than 20 in men and less than 25 in women. However, it is important to interpret that the results according to the assay-specific reference ranges, they vary. And they also vary with certain physiological conditions, pre or post-menopausal status of the female. A single prolactin value above the upper limit of the normal can be sufficient for confirmation of hyperprolactinemia, provided that the blood sampling took place without excessive venipuncture stress. We discussed in a couple of slides prior that if the patient was stressed at that time, to an extent that the venipuncture was really stressful, it can certainly raise the prolactin level. If there's a doubt, particularly in cases where there is mildly elevated prolactin, sampling should be repeated at around 15 to 20 minutes interval to account for the pulsatility. Now, in the first few slides, I had discussed the size of prolactin, which might appear not so important. Let's see why we discussed about these kilodaltons, 23, 50, or 150. We are going to talk about macroprolactin. Most circulating prolactin, which is of the size of 23 kilodalton, it's the monomeric that accounts for the 85%, which is the active form, which is responsible for the biological action. Now, however, serum also contains larger isoforms or dimeric prolactin, the big prolactin, or a polymeric prolactin, which is big prolactin, which is more than 150 kilodalton. That is the monomeric form only combined with an IgG antibody. Now, when there are macroprolactin in mostly complexes of IgG or IgA or polymeric aggregates of highly glycosylated prolactin monomers in most individuals, the majority of prolactin will be monomeric. And in others, there is a preponderance of macroprolactin referred as macroprolactinemia. Now, detection of macroprolactin is clinically important to avoid incorrect diagnosis and unnecessary investigation. For example, if the patient does not have any symptom and these levels are markedly raised, you can actually order a test for macroprolactin levels. And if you find out that they were there, there's a way they conduct the test. They can actually rule out whether it was the prolactin monomers or there are really macroprolactinemia, which is falsely giving a report. Since the patient doesn't have any symptom, we should know about something called the big prolactin. The second effect I want you guys to know is the hook effect. It is encountered in the presence of excessively high prolactin. Imagine there is too much prolactin so that it saturates the antibodies when they are doing the tests in the lab. Now, failure to recognize this effect may result in missing the diagnosis of prolactin and taking an incorrect therapeutic decision. Let's say there's a large pituitary macroadenoma, more than 3 centimeters, with an expected prolactin level of more than 10,000, presents with only mild hyperprolactinemia. Now, that should raise suspicion for the hook effect. It is easily overcome by the people in the lab. They just have to manipulate the dilution, that is 1:100, and leading to washout, and they can actually give you the actual report, eliminating the excessive unbound prolactin. Now, time and again, we have been discussing certain cases in our various groups, primarily live CME. And there was this question coming out. This was the report. This is a level of prolactin that we got from my patient. What do we do now? Let's say it was 70. And once there was a report which was around 90, once there was a report which was 118, and we're still in a fix whether it is drug-induced. So is there a range which can be taken as drug-induced? Is there a range that we can specifically tell that, okay, fine, tumors lead to this? Remember, there's no direct correlation. A tumor can have levels of prolactin 70 nanogram per ml. If at all you have to remember a range, I would want you to look at this slide. And in the drug section, Remember, it is mostly between 25 to 100. If the range is between 25 to 100, rule out the basic things which we remember: physiological, pathological, and pharmacological. Out of the pharmacological, the drugs which we know we use most of the time, primarily first generation. In the second generation, risperidone, amisulpiride, or sometimes other agents such as levosulpiride. Remember, the pines are least likely to cause. Almost nil would be aripiprazole and clozapine and ziprasidone. Now, if you have levels which are more than 100, that should raise the suspicion that something else might be there. Macroprolactinemia can have levels more than 200. Well, you should take care or look for the hook effect. If at all the levels are too high, an endocrinologist should be taken in the loop. If you're doubtful, the report can be discussed. Let's say you're pretty sure that your agent is not causing, or what you did was you told the patient to taper down or stop the medication if it is possible for a few days. Let's say for 72 hours the medication was stopped and you repeat the test and the levels came down. It was probably because of the drug. In case it doesn't come down, or you change the medication, and let's say the patient was altogether shifted to aripiprazole and the levels are still the same, that should raise the suspicion that something else might be accountable for the raised level of prolactin, which are more than 100. Out of the other causes, if I have missed one cause, that is hypothyroidism. Remember, hypothyroidism and not hyper can lead to raised level of prolactin. Now, coming on to when do we need to, or let's say in the workup of hyperprolactinemia, there comes a point that you have to get the MRI done or neuroimaging done, or the patient insists, doc, I want to rule it out. Now that it's in my head, I've Googled it, I can't help but think about whether there's a brain tumor, whether I'm going to die, because I can't sleep now. You have to tell me. Now, instead of telling the patient to go for a CT or just writing MRI brain, you have to remember that the gold standard is the contrast enhanced pituitary MRI. If you can link with or discuss the case with the radiologist, the best thing would be ask the radiologist to do a dynamic pituitary MRI scan, which is gadolinium enhanced. Dynamic would simply mean when he takes the images after giving the dye will be slowly given, and within an interval of, let's say, 10 seconds, 20 seconds, the slices will be taken and the pituitary will be taking the dye inside. And if at all there is an adenoma, it will be quite visible. Just getting an MRI done without telling what to look for may come as a normal MRI, and the patient actually could have an undiagnosed pituitary adenoma, especially a microadenoma. There is something called non-functioning pituitary adenomas. Nonetheless, out of all this complex slide, one thing that you have to remember, there is no prolactin cutoff value with a perfect diagnostic value differentiating prolactinoma from other tumors. So yes, they do give us a range. Yes, between 25 to 100, you can think of drugs. Beyond 100, you should start thinking of certain other things. Yes, we have to rule out physiological causes, certain pathological diseases such as kidney failure, liver failure, or certain medications, depending upon what the levels are. 99% of the non-functioning pituitary adenomas had serum prolactin of less than 2000, suggesting, or around 100 micrograms per liter, suggesting prolactin above this limit is most likely consistent with a prolactinoma. Rarely long-standing untreated primary hypothyroidism can cause significant lactotrophs hyperplasia, which we may mimic as a pituitary adenoma. There's a case that I'd like to discuss before moving on to the next slide. It's a case of, now that we know the causes which are drug-induced, and we also know the causes which are pathological. There's a case of a 24-year-old female. Simply, she's an unmarried female. She developed symptoms of First symptom was galactoria. She became worried. To an extent, she was scared what is happening. Yes, she was sexually active, but there was no change in the libido. She went to the doctor. Certain tests were done. Our basic blood tests were done. Thyroid, basically hypothyroidism was ruled out. Ultrasound abdomen was done to rule out PCOS in that very patient. A complete drug history was taken, which revealed that at once she was on lithium and escitalopram, but currently, I think more than 5 years, I believe, she was not on any treatment and she was doing good. So no temporal relation. She was not on any antiemetic or any other medication for that matter. Taken the family history, it was something weird. On the paternal side, there was the history of there was macroadenoma and there was a history of depression. And on the other maternal side, there was the history of Parkinson's disease. Now, given this history, the patient got scared. And since the other tests were coming normal, she got her prolactin levels done. The levels came around 70. Now, that got her in a fix. Well, one of the doctor told that this could be drug induced, you might have taken something. But she, being in this field, had a hunch that no, I have a very strong family history, even of a prolactinoma. I think I should get an MRI done. She went to a neurologist. Well, the neurologist ordered the contrast enhanced MRI, and they found a microadenoma. She was put on treatment. She was put on cabergoline. It was started twice in a week with a dosage of 0.5 milligram. Usually, the adenomas or tumors lead to headache. She did not have the headache earlier. In fact, after starting cabergoline as a side effect, she developed headaches, specifically on the days and on the second days when she used to take. After 6 months, the doctor told him to taper it down and then stop. And there was another MRI done, which revealed that the size has shrunken to a certain extent, but it had not gone. So she was again told to restart. It's been 3 years. She's currently on 0.25 milligram of cabergoline twice a week, and she's been told to continue it. And her MRI is being done every 1 year. The point is, she has had a history of depression. Yes, there was another history of schizophrenia in her family. Apart from that, there could be a dual diagnosis. Sometimes a patient could have a family history or perhaps a psychiatric disorder, and along with a condition such as adenoma, which could be rare. But since looking at this case, since there was a suspicion that what could be the cause in her case, the lesson learned in that condition was to keep in mind the dual diagnosis, even though it was not present in her case. Discuss the case because we, in the further slides, would be discussing about a little bit about dopamine agonists such as cabergoline. Now let's look at the diagnostic algorithm. In order to confirm hyperprolactinemia, we should exclude macroprolactins. We should exclude physiological condition, get a UPT done in premenopausal women. We should exclude primary hypothyroidism, drugs which can raise prolactin, PCOS getting an ultrasound abdomen done, getting RFT, LFT done along with the ultrasound can give us an idea whether the patient has kidney failure or liver failure. If all the things are coming and you don't find a cause, go for the contrast enhanced pituitary dynamic MRI scan. What should be the treatment goal once, if let's say we have to start the treatment for hyperprolactinemia? Rule number one, the patient has to be symptomatic for you to worry whether you should need to start the treatment or not. If you have to start the treatment, the goal should be to restore the normal gonadal function or fertility. Second, in the long term, prevent osteoporosis. Management based on etiology. If there is an adenoma, you have to be managed. Mostly it is medically managed with agents such as dopamine agonists such as bromocriptine or cabergoline in the case we just discussed. Group 2 will be patients who have macroadenomas. Well, they might need fertility management in combination of drugs with surgery, bleak radiotherapy. Third is the group in which the patients, let's say psychiatric patients on medication or patients with psychiatric illnesses who are on drugs which can lead to hyperprolactinemia will be that group, and we'll be taking care of that. Now, specifically pertaining to our field, let's say we have case which is drug induced and there is one of our agent which has caused hyperprolactinemia. How should we go about it? The rule stays the treatment of hyperprolactinemia depends more on symptoms and long-term risk rather than the report of the plasma prolactin level. If the treatment is required, switching to an antipsychotic with lower liability for prolactin is usually the first choice. Remember, these are guidelines and it can vary from case to case. It is the psychiatrist or the doctor in charge who has to decide which is the best thing for the patient, because switching always carries a risk of destabilizing the illness and causing a relapse. And relapse in a schizophrenic patient or a psychotic patient can lead to a poor outcome or a disastrous sometimes prognosis. An alternative is add aripiprazole to the existing treatment. Now, the next question is what dosage should be add? It was seen that around 2 milligram, 3 milligram, and up to 6 milligram, higher the dose, better the effect was seen. It was not much benefit was not seen beyond 6 milligram, but that is again debatable. As psychiatrists, we have tried aripiprazole as an augmenting agent. We've gone up to 10, 20, 30 in certain cases. There has been improvement, and in certain cases there has not been improvement, and eventually we would have to shift the patient from other agents to completely on aripiprazole or the pines. Now, what to do if the patient cannot tolerate aripiprazole? Well, at that time, dopamine agonists such as cabergoline can be effective. Amantadine, cabergoline, bromocriptine all have been used, but each has theoretically at least the potential to worsen psychosis. Remember, we are using dopamine agonists. Now, remember this line that it is a theoretical possibility. If you are using cabergoline under the protection of antipsychotic, it is least likely that the patient is going to go or have a relapse or have florid psychotic symptoms. In the trials, it was never really reported. So we can consider it safe. If at all we have to use such agents, we can use, for example, the dose of cabergoline would be 0.25 to 0.5 milligram once weekly or divided dosage in twice weekly. Maintenance would be from 0.25 to 2 milligram. Dopamine agonists are effective at normalizing prolactin levels and achieving tumor shrinkage as well is something which you should remember. Specifically in her case, the tumor size shrank in the successive MRIs, and some get it done 6 monthly, some get it done annually. We can get a broader picture while we discuss it with the chairpersons. We've discussed about aripiprazole as an augmenting agent. These were the trials done in which they augmented the primary agent with aripiprazole. Approximately after 4 weeks, serum prolactin levels were normalized. There was a question raised once that even after switching, the periods have not been restored. Yes, it does take time for the action to come, or the normal menstrual cycle to come into place and get regulated. It doesn't happen abruptly. Yes, the prolactin levels may come down first. The actual physiological effect may come down later on. This is where the team action or the teamwork with an endocrinologist can help the patient. Aripiprazole, it deserves a special mention for its particular mechanism of action. As we know, it is a partial D2 and 5-HT1A receptor agonist. Consequently, the drug does not significantly increase prolactin. Even it reduces when associated with another antipsychotic. Aripiprazole lowers prolactin level in dose-dependent manner. 3 milligram per day is effective, but 6 milligram per day was more so. Like I said, it is debatable. We do see, and we have had this discussion quite a while ago, that the dose actually doesn't matter. You can go higher in certain cases and even switch to this molecule if the patient is getting better on aripiprazole. A brief overview of the management. This has been taken from a guideline, Maudsley's guidelines. It is not mandatory to be used in a country, but we do get a hint that how should we approach a case of hyperprolactinemia. Let's say for all patients, we get a baseline of prolactin, which in Indian scenario is difficult. Hence, you take a history of sexual functioning on the baseline and you write it down on your first prescription. After 3 months, asked about prolactin-related symptoms, if the patient reports of certain symptoms, male or female, or you see any sign, let's say there's obvious gynecomastia, the guy is gaining weight and is reporting of decreased libido, start thinking about raised prolactin. The range, as we remember, less than 20 in men, less than 25 in women is normal. More than that, it is elevated. Between 25 to 100, remember, drugs can be the cause. More than that, you have to start thinking about other causes. If the levels are elevated and the patient is symptomatic, the term is symptomatic, switch to an antipsychotic with lower liability for plasma prolactin elevation, such as the pines. If it is not appropriate or not successful, add as an adjuvant aripiprazole. If it is successful, consider slowly reducing the dose of prolactin raising drug and aiming for aripiprazole as the sole treatment agent, which may or may not be possible in certain cases. Only if the strategy fails is considered clinically inappropriate, long-term combined antipsychotic should be considered. And if at all you have to do that, remember, osteopenia, osteoporosis is something that you have to remember, because when the patient is on that medication for years, let's say other symptoms were not that prominent and the patient develops or has a fracture, that should have been taken care in the earlier days by us, obviously. Now, let's see the other side. If the symptoms are not there, but the levels are raised, discuss the clinical implications of the test results with the patient. Take a joint decision. If the patient already knows that the prolactin levels are raised, trust me, he's probably scared to death that there's a tumor inside because of certain privileges which are available on internet. Take a joint decision whether to continue the current treatment or with annual monitoring, which is very easy to do, or switch to another antipsychotic. If the switch is not appropriate, well, the same strategy, add aripiprazole at the dosages of 2 milligram, 3 milligram, 4 milligram, 5 milligram, even 6 milligram. If the patient doesn't tolerate, there are other strategies such as dopamine agonists. In certain studies, even the use of metformin was helpful, especially in females who, along with that, had diabetes or along with that had PCOD. This was more or less from my side. Thank you so much for being patient listeners.
Thank you so much, Dr. Jagjot. Wonderful presentation as expected from you. So, thank you so much. If the chairpersons are there, I think Dr. Shreya had some medical emergency. So if she is there, otherwise, and Dr. Veda is if she's there. Opening remarks, then we can go to the question answers. Questions are invited in the chat box. You can all put it there.
I think Dr. Veda is in a bad network. Let's start with, and I'll message her to
I
join.
think, yeah, Dr. Sakib, he's an endocrinologist, he's there. Dr. Sakib, can you raise your hand if you're here? Anyways, if Shobir and Vishal, can you help take the questions from the chat box?
Yes, sure. Shobit boss, why don't you start?
Yes.
I'll
Dr.
message Dr. Veda.
Very comprehensive presentation. We have some drug-based questions like what about prolactin levels with cariprazine, bolancerin, and the recently launched in India premavanserin. So all the three.
Sir, all three are very novel new molecules. One I can say with the experience is cariprazine at higher dosages does lead to EPS as good as any other molecule. It can lead to raised level of prolactin. Mentioning the other two, I don't really have much experience with them. Neither there have been like studies which are comprehensive. It can give a conclusive evidence whether they lead to of all the studies that I could gather, and even for the Maudsley guidelines. Even if they come out with, they are going to put them in the least likely category because the evidence wouldn't be. But that wouldn't mean that they were not able to cause. For example, cariprazine, I couldn't find it in the lists, but clinically it has seen to cause at the dosages of more than 3 milligram. Even from 1.5 to you shift to in certain patients 3, and the patient starts to appear to have EPS. Definitely at 4.5 and 6, there was only few of them could tolerate 6 milligram without having EPS. So yes, more the dopaminergic occupancy, especially D2 receptor, more the antagonism, more the antagonism will lead to secretion of dopamine, and with the equation, the prolactin will rise. Hence, theoretically, it can be told if the agent has more receptor occupancy, it will invariably lead to hyperprolactinemia.
Right. A question related to this, if some patient has a lot of other possibilities of prolactin increase, how will confirm that it is drug induced?
Well, definitely we have a list of drugs, but first, before jumping to the drug, I would want all of us to remember that stress is one factor which can mildly increase prolactin levels. So we always have to account for it. Even if when I tell somebody to get the tests done, I tell them you have to relax for at least 20-30 minutes. Don't go rushing to the lab that you're getting late for work. If that is the case, just go there, sit down for 20 minutes, relax. If you're scared of a needle, instead of getting a venipuncture, get an IV line, wait for 10 minutes, and then take out the sample easily in a relaxed state. If you have been climbing the stairs, have done some activity which was rigorous, that includes sexual activity, I would ask them to take a gap, refrain, and then give the sample. That could rule out the stress induced. Others would be simple physiological. In one of them, it's a young female discussing about pregnancy or getting a UPT test will rule out certain physiological causes. Then simple, we get the RFTs done, LFTs done, or if the patient has icterus, we know the patient is in liver failure or has a history of CLD or ascites. So we get a hint of it, or patient is a known case of CKD, and our agent is less likely to cause or can actually attribute to it rather than single-handedly raising the prolactin level. Last of all, the notorious drugs, risperidone, amisulpiride, first generation antipsychotics are the ones which are known to cause. And clinically, it is quite visible at times to know if the patient also says, and we see the signs, it is relatable. The temporal relationship is there, that once I started the molecule, the symptoms appeared. Taking a history of sexual functioning prior to starting the molecule is an easy way of going about it. Definitely, if we go with the Maudsley guidelines, they say that when you're about to start a drug which has a high propensity to lead to hyperprolactinemia, just get the prolactin level done at the baseline. In fact, many of the doctors or senior psychiatrists do get it done on the day one of their visit in certain patients, which sometimes are potentially a legal suit.
Just adding to this antipsychotic, in your research, have you found what is a good dose of aripiprazole in reducing hyperprolactinemia?
One, it was told that it is dose dependent. In one of the studies, Maudsley says that between 3 to 6, and 6 is better than 3, and beyond 6, they said no further change, no additional benefit was seen. Had a discussion with one of the psychiatrists, and he bashed me up. He told me, "Aisa nahi hota hai." So he said that aripiprazole can be taken to a higher dose, and it will help you. So go ahead. My take would be adding aripiprazole. If it helps, well and good. Otherwise, just keep increasing aripiprazole and decreasing the other agent to a point where you can reach that the symptoms are not there, and also the symptoms of the psychosis or the primary illness is not there, and also the symptoms
I
of
think we can have a little discussion here. I think it's an important point, and I think in my experience, like you say, Jadrut, when we go in higher doses of aripiprazole, we lose the efficiency what we look for. I mean, it starts behaving more like a typical antipsychotic. at 30 milligrams or higher, you know.
Yes.
So I would like maybe if Alim or Dr. Veda, Tufan sir, or Shobet, if you want to pitch in here and see, does this change with the higher doses of aripiprazole? Because this is an important thing. A lot of people do report it helps with lower doses, but not in higher doses. So want the house feedback also on this.
I think, sir, it is inter-individual. So we have to actually individualize it. So lower doses definitely help, but again, it is not, there is no broad consensus on dosages. That is why every guideline will give you a different dose. Jagjot, I think you very well answered this question. I'd like to add that for drug induced, confirming drug induced, if you stop the drug and there are levels falling within 3 days, then more or less it confirms that it is because of the aforesaid drug is an offending agent.
Right, right.
And I think there are a lot of other questions like what should the frequency of prolactin measurement when you know the drug is the offending agent? So at how frequently we should subsequently measure prolactin?
Well, once the symptoms are there, we go for measurement of prolactin. Then if the levels are raised, let's say between 25 to 100, then we remove the offending agent. That is going to be the first choice if we are able to, not risking the risk of, not risking relapse. We take off the agent, we get it retested after 72 hours. It depends on one, how much occupancy that molecule has done, how long it stays in the body. So if let's say it has a very long half-life, it stays longer, it'll take a longer time to come down. So in those cases, we may have to wait up to 7 days. Second, the absorption of the drug in the adipose tissues. There are certain molecules which are absorbed in the fat cells and they're slowly released. Then the levels of prolactin will not come down faster. And that is these two specific occasions where the result will be late. Otherwise, after 72 hours, we get it done. And then again, after around 1 week, there are no strict guidelines which say, I usually stick, if I have to, 72 hours, then I tell the patient that we bring it down. We tell me if there is a change in the symptom and we'll repeat after 1 month. If the patient is not worried too much, and if the patient is worried, then definitely it's the clinical judgment on the spot that decides what action to be taken.
So, Jagjot, suppose you also talked about it in the presentation. What are the clinical indicators before doing prolactin test that prolactin may be high in those persons? Any clinical indicators that we should be aware of, or we should do it in everyone?
Right. So the clinical symptoms would be divided in male and female. Commonly would be lack of libido, infertility, gynecomastia in males, galactorrhea in females, amenorrhea, oligomenorrhea, females may hirsutism, sudden facial growth, and then along with that, there is increased or weight gain. When these symptoms start appearing, even acne along with menstrual disturbance, most common, majority cases, more than 90% of the cases, symptomatic hyperprolactinemia presents with galactorrhea, especially in females.
So there was one question about premature
ejaculation.
Whether it is
Shobit, just a moment. Yes. Dr. Sakib, if you are there with us, let me introduce Dr. Sakib. He is an endocrinologist, friend in Lucknow. So just got hold of him. Dr. Sakib, we have sent you some slides also that we are presenting. You might have missed the presentation. So basically it is on prolactin for psychiatrists. Some medications do it, some other conditions do it. So if you want to go through the slides that you have sent, it is okay, or we can ask some very basic questions.
Yes, you can. Sir, actually, I have not gone through the presentation. I've just joined that. I found it interesting. It is an interesting discussion, and actually, it is a problem which we face a lot of time, and we know that the antipsychotics and the cabergoline, they are counterproductive when we are going to treat drug-induced hyperprolactinemia. They would lead to they would lead to ineffectiveness of the antipsychotic treatment which a psychiatrist is giving, and if he is giving it and he cannot have any other option, then it is going to have hyperprolactinemia. So as he is saying, we must know that why we are going to do it and why we are going to test it. So you were asking about
What are the clinical
this.
indicators? Suppose a person, we test prolactin, it is come high or low. So what are the clinical signs, suspicions that a person may be having, male or female may be having
So
high
in
prolactin?
male, whatever problem it is creating is because of hyperprolactinemia induced hypogonadism. So if the patient is having hypogonadism and the patient testosterone is low, and the patient is coming to you with biochemical confirmation, because the hypogonadism symptom is also very non-specific, and a lot of time when the patient is already having depression or anxiety or any psychotic illness, it would be very difficult that we would not be having any specific symptomatology in such patient. But if the patient is having any confirmed hypogonadism, like biochemical evidence of low testosterone, which has been done rightly, and the patient is having symptomatology also, then it may be due to hyperprolactinemia. Like I have diagnosed two patients in the last month per se, when the patient has just come to us with lack of secondary sexual characteristic, where it was just a matter of very of just the formality that we'll have to have it. Otherwise the patient was not having very strong suspicion of hyperprolactinemia, but the patient was having this macroadenoma in one case and microadenoma in one case. So it is always rule that we should go for biochemical uh, confirmation when the patient is having a specific symptomatology, and then only we should go for imaging. So, and in female, where it is required, it for luteotropic action, when it is in excess, the patient would be having oligomenorrhea. The patient might have galactoria. When the patient is having such thing, then definitely we should look for biochemical evidence of hyperprolactinemia. Most of the time when it is up to 200, it may be just because of the drug induced thing, and where taking the offending agent off for 72 hours, as he is saying, most of the time it would come to normal. So but if we have just treated it symptomatically, which is a lot of common scenario when the patient visit any gynecologist, so we should not treat the individual reading, but we should treat the patient in toto. We should not try to just bring it with one dosage of cabergoline, as he's explaining that because its mechanism, its duration of action is quite long. We should always look for the reason that why it is elevated. If it is due to drug induced, if it is drug induced, it is not going to cause any problem. The problem in female would be associated with hypogonadism. The lack of female steroid would lead to decrease in bone mineral density. If this is not the concern, if this is the concern, we might treat it. If the patient is not having any reproductive concern, then even we might not treat hyperprolactinemia, which is even due to prolactinoma, microadenoma of the pituitary in some of the cases. So we should not treat it without knowing that why we are treating the patient, why the patient has come to us. Only ordering a test when we are not sure that why we are ordering it, it is actually the basic rule that we should order it only when we are certain that why we are going to order it. Like we used to
Doctor,
order it
yeah.
in case of PCOS, where a mild hyperprolactinemia is a very common thing, but we per se don't need to treat it with anti uh, those dopamine agonist option like cabergoline or those things.
So, Dr. Saqib, one add-on question. Suppose treatment of high prolactin is neglected. So what are the expected problems in non-treated hyperprolactinemia?
So
Suppose
one
we are
is
not treating, we
so
missed out or we neglected it. So
so
what
as
will happen?
as I've explained, one is reproductive function. So in those who like when we talk about the female, when they are in reproductive age, they might face the problem related to their reproductive their menstrual cycle. They might have irregular menstruation. Apart from that they might have their concern with fertility. They might have primary or secondary infertility, for which we need to treat it. If the patient is not requiring fertility or the patient is postmenopausal, then uh, our cons our concern may be other things, like when the patient is having macroadenoma and it is leading to any other like it is causing compression to rest of the pituitary and it is leading to panhypopituitarism. If it is invasive, then we need to treat it in any case. So but if it is microadenoma and the patient has passed their reproductive phase, and the uh, patient is not concerned about just the biochemical elevation, we even might not require treatment also. But it is one such condition where a treatment is very easily accessible. The medical management is is the gold standard of treatment, even if it is macroadenoma. Only there are specific situation where we should involve neurosurgeon a lot of time. When the patient are not requiring this surgery, a lot of time they are referred to neurosurgeon, and even they would be facing more hazards of surgery as compared to even not treating them when they are having just microadenoma, which can have a very good outcome of medical management.
Thank you. Dr. Sakib, if you have time, please stay online. So we'll again rope you in.
Okay.
Yeah. Shobhit, Vishal, questions from the chat box, please.
So there is a clinical question to continue that Dr. Sheila has asked this. If a patient is doing well on antipsychotic medication, if it just found that prolactin was high in routine test, should I change the medicine if patient has no symptoms of hyperprolactinemia? Partially it is answered by Dr. Sakib. Jagjot?
Well, if there are no symptoms and the prolactin levels are slightly raised, nothing to be done. You can continue with the treatment. One should always be worried once the symptoms start to appear. Also, if the levels are too high, if the levels are mildly raised and patient does not report of any symptoms, which is most of the times that is going to happen in the OPD, nothing needs to be done.
And I think only exception is children, because in children, adolescent population before bone fusion, if prolactin is high, even if there are no symptoms, I suppose that we need to subsequently then look into the molecule.
Even children start developing gynecomastia.
Correct. If they are not symptomatic, still I think in case of children, UK guidelines says in case of children. Vishal sir.
Vishal, you're on mute mode.
Dr. Kamran has asked, can generalized anxiety disorder and severe OCD with high stress levels cause persistent hyperprolactinemia?
Well, definitely.
So let me add. So Jagjot, you mentioned exercise, nipple stimulation, all these can cause hyperprolactinemia. So excessive stress can also cause hyperprolactinemia?
Yes, definitely, yes. That is one point as psychiatrists we should always know, that stress itself is one of the most common causes of mildly raised prolactin levels, which are reversible. You repeat the test and they come down normally. If we test it again after 72 hours or 96 hours. The protocol suggests that repeat after 7 days and then 1 month. If the follow-up tests reveal that the levels have come down to normal, or even on the second test, there's nothing need to be done.
But mild, still not be severe.
Definitely
or high.
mild. Definitely mild.
Only mild. Only mild, right? So if it goes
right.
beyond mild, like you had given the category of mild, moderate, and severe, then we have to think of other causes, right? If it's beyond mild. Okay.
Right.
There's another question. If already on treatment for hypothyroidism and has raised prolactin and is on risperidone, how do we proceed?
Well,
Question.
I think
I think Dr. Shakib answered. Dr. Shakib?
Sakib should also opine. I'll just like to add first that if the patient is on risperidone and the primary hypothyroidism is adequately treated and the prolactin levels have not come down, then it is probably because of the antipsychotic, right? And if the levels are risen and the patient is symptomatic, then we need to do something about it. The first would be switching the agent as per the guidelines. You can just lower the dose. It's a dose dependent mechanism. You lower down the dosage to the minimum effective dose. If the symptoms are not reappearing and the levels have come down, you can continue with the treatment. Secondly, you add aripiprazole. Aripiprazole can lower the prolactin levels within a dose range of 2 to 5 milligram, 6 as per Maudsley. Within that dosage, it can happen. Or you remove risperidone, shift the patient to aripiprazole. The second part, primarily how hypothyroidism is related to raised prolactin, I think Dr. Sakib would be able to explain better.
So actually, very severe overt hypothyroidism where TRH is elevated, that is actually responsible for prolactin release. And even if it is just subtle elevation of TSH, it is not going to lead. It is not going to cause any hyperprolactinemia. So it is only very severe overt hypothyroidism where T4 is also low, TSH is very high. There is a TRH mediated prolactin increase, which is not usually the case in case of mild hypothyroidism or subclinical hypothyroidism, or in case of absolutely good control of hypothyroidism, it is definitely not a concern.
Sakib, I think cavagolin is the most commonly used medication for hyperprolactinemia. So can you tell us what are the precautions, how it should be given, and what are the side effects, problems with cavagolin? How should we be careful about it?
So actually, we should start with the lower dosages, and we should the main problem is that it might be associated with postural dizziness and postural hypotension. So we should take it at bedtime. We should start with it with the lower dosages, and then only we should update it like 0.25 milligram twice a week, or such dosage initiation would be enough in most of the patient. Sometimes we might require 0.5 milligram twice a week. And then we can subsequently increase when the patient can tolerate, because it is not an urgency. Most of the symptoms are benign. So we should start with the lowest dosages like 0.25 milligram twice a week, and then only we should up titrate according to the response.
Okay, any major drug interactions
should
of
take
it?
it at bedtime when the patient is just going to sleep, so that the patient is not having any postural dizziness also. We should advise the time as well as the way with which we are going to introduce this drug, and we are going to up titrate it.
How long should we continue it?
Sorry, sir?
How long should we continue the cavagolin?
At least for 2 years. Even for microadenoma.
Question.
When
Yes.
the patient is having microadenoma as the reason of hyperprolactinemia, at least for 2 years, when we go through the literature, it says that we should give it for 2 years. Though there is no consensus, there is no specific cutoff, but there was previously a concern of regurgitation and those things, but it is only with the higher dosages which is being used. With the dosages which we are using with in hyperprolactinemia, it is not responsible for those problems. So it has been found that when we are giving it for less than 2 years, and even when there is no imaging evidence of microadenoma which was there previously, the chances of relapse is higher. So in the endocrine society guideline, they say that at least for 2 years we should give.
So
I think Dr.
Doctor,
Jagdish.
even if it's
With the case that we
our
have
medication.
discussed, the patient, it's been more than 3 years and she's still on treatment. And the second part of your question, Dr. Vishal, would be, sir, how frequently should we go with the neuroimaging? Let's say we've got a baseline done and then the size was known, and let's say 1 year has passed. So what should be the duration or the gap between getting the neuroimaging or getting to know the size of the tumor?
So you are putting, you are asking it.
Ji, sir.
Okay. So we should not order any re-imaging at least before 1 year. We can only order it after 1 year. If the patient is showing any symptoms, like the patient was having any macroadenoma which was near the optic chiasm, and the patient is not now having those symptoms in the perimetry, that the visual field is being compromised. If the patient is like, there are some specific scenarios, like the patient is pregnant and the patient is not on treatment, but the patient is still showing the compression of optic chiasm, then we might require MRI. So there are specific situations where you might require earlier investigation, but not before 1 year. It is going to have any benefit.
Right. I think there's a tunnel vision as a symptom that appears if the compression symptoms have started. It's called homonymous. Right.
There's a question on endoxifen. What is the effect of endoxifen on prolactin levels?
Well, literature-wise, it does not have or does not produce certain reproductive side effects. In clinical psychiatric OPDs, we have discussed that some patients have reported certain reproductive side effects. Again, it's a new molecule. The answer is going to be debatable. Given the mechanism of action, the likeliness of that happening is very, very less.
Okay. So what are the medications that are less likely to cause Jagjot? Just revising the topic.
Yes,
Suppose we are not talking about antipsychotics now.
Yes, sir.
Antidepressants, mood stabilizer, all these medications,
Right.
relatively safer ones.
So we'll discuss all of them in very brief. So antipsychotics, we should always be wary of first generation. They're very notorious, specifically haloperidol and chlorpromazine. ये चल रहे हैं, prolactin बढ़ने के chances हैं, at least more than 50% or even up to 80%. Second generation, supposedly least likely to cause or less likely to cause compared to first. But if you have risperidone and amisulpride, they can raise comparatively as first generation, even to an extent of 200, even to an extent of 300, which has been reported in literature, risperidone. And once you stop it, the levels will come down to normal. So this is drug induced, right? That's where the answer given by Dr. Shobhit comes into the picture, that you stop it for 72 hours or 96 hours and you repeat. And when you see that the levels have started to come down, you repeat after 7 days and then you repeat after 1 month. If the trend is falling, then it was clear cut that the drug induced was there. So amisulpride, risperidone, to some extent, levosulpiride, these are the agents which are notorious. Pines are relatively safer, clozapine, olanzapine. Legally, theoretically, if one medication that you should always think of while you're dealing with prolactin, and amongst the antipsychotics is aripiprazole. It has the property of decreasing it as well as single-handedly can take care of psychosis in certain cases, not always. Antidepressants. First antidepressant you have to remember, the most notorious, more than 50% of the cases, clomipramine. Amongst SSRIs, all can cause notorious fluoxetine. TCS, more likely than SSRIs. Amongst TCS, most likely clomipramine, less likely amitriptyline. MAO inhibitors definitely cause. SSRIs, remember, fluoxetine. Others can also cause. Most of the time, antidepressant induced is asymptomatic. So we don't really have to do anything if the patient comes with the report of mildly raised. Unless he does not have any symptom, continue the SSRI. Getting prolactin done, levels done on a patient on SSRIs, which is asymptomatic, would be our own kind of error in judgment, because that will open the Pandora's box.
SNRIs?
SNRIs, again, not one has popped out of the equation. It has to have action on certain dopamine receptors. Let's say if we have certain agents of such as metoclopramide, perenone, any agent which has dopaminergic action, anti-dopaminergic action, has a propensity to increase prolactin. More the action, more the likelihood. SNRIs are usually considered safe.
Any words on metazapine and bupropion?
Least likely. If you want to be safe in your OPD, and then again the word is legally safe, there is no worry to then yes, definitely bupropion and bupropion will increase the dopamine, so it is not going to cause prolactin. So similarly, mirtazapine is one of the safest amongst the lot.
And valproate, carbamazepine, oxcarbazepine, lithium.
Well, out of them, I could find literature that clearly relates to raising the levels of prolactin. So would not categorize them in any of the lists. Even in the mostly, Dr. Shobit can fill in with his, since he is much more experienced than me. Literature-wise, the book articles that I've gone through trying to find out other agents which rarity can cause, couldn't find them.
Okay. So basically what I gather is what from Dr. Sakev also, that medication-induced prolactin is not a emergency, not an alarming situation, can be managed quite well.
Yes.
So the thing is ki you have to rule out other causes of prolactin, nitrogenous and nitrogenous, those sort of things.
Right.
Okay. And you should treat because it will cause dysfunctions, sexual dysfunctions and osteoporosis, ischemia, these sort of things.
Gynecomastia, galactorrhea, sexual dysfunction such as erectile dysfunction, lack of libido. Docs, I don't feel like having sexual intercourse. What has happened to me? Erection has gone. Something just happened.
Yeah, somebody activated that's all right. Taken care of. Anji.
Okay, so on and so forth, the same symptoms. You should always be
Okay,
worried more about female population while treating with antipsychotics, with the agents which are more likely to cause, because the damage in them can be detrimental. Also, if we suddenly stop the antipsychotic, the damage is going to be of a lot of value if the endocrinologist says that you have to stop it. Good thing is, if the liaison exists between the endocrinologist, give him a call that this report has come and sending the patient to you. You need to calm the patient down, because if the patient comes to us with the report, reported something or gotten that done from outside after Googling, the patient is going to be scared of a brain tumor, right? You have to calm him down or her down, and also get an endocrinologist in the loop. If two people from different fields are telling the same thing, the probability of the patient agreeing with the doctors is going to be higher than he himself thinking about what possible wrong could happen. And they get an MRI done by themselves or CT done. You have to remember that you have to do a contrast enhanced gadolinium MRI with the dynamic cuts.
Okay, and usual strategy in antipsychotic is to shift towards aripiprazole or add cabergoline.
Yes, sir. Even doctors were discussing that there we might be worried. Theoretically, it's a possibility. Even in the trials, there was no florid psychosis, no relapse of symptoms when cabergoline was added. You have to remember that under the blanket of antipsychotic, you can start cabergoline at a dosage of 0.25 milligram once or twice a day, twice a week, and then continue it. If required, go to 0.5 milligram twice a week and then continue and monitor the level of prolactin if they are coming down. You can go up to 2, even 3 milligram, which is a rarity. Now, for us to be worried about cabergoline is not the risk of relapse, is my message. It is, once you give a dopamine agonist, it leads to impulse control disorders. Now, I'll be worrying about gambling. I'll be worrying about sexual addiction. I'll be worried about the patient being kleptomanic now. I'd be worried about, the patient having explosive anger. Or, there's a term called punding, when the patient starts to disassemble and assemble objects in the house. ये बाकी सब ठीक है सर, ये घड़ी को सारा खोल देता है और फिर उसको जोड़ देता है, वो यही करता रहता है। ये क्या कब से करने लग गया है? इट्स द इम्पल्स, इट्स फंडिंग दैट इज a dopamine agonist doing in our case. These are the conditions like we discussed in the first slide. Two things, two parts. One, are drugs causing hyperprolactinemia and that leading to certain symptoms? Two, our drugs are not causing dopamine agonist, or somebody is treating hyperprolactinemia and patient develops psychiatric symptoms, primarily impulse control disorder or those symptoms. And other conditions which can present similarly, we all know that in Parkinson's, patient develop impulse control symptoms. In patients of restless leg syndrome, we use ropinirole or certain dopamine agonist, and they again start developing symptoms such as sexual addiction, which is earlier not there. And the patient comes, why am I now obsessed with gambling? Why am I now obsessed with sex? I am shopping throughout the day. And you think, oh, the patient has turned meaning. No, the patient has not turned meaning. He's just shopping more than usual. And he himself is not able to control it. This is something that we should know when we use dopamine agonists.
Very nicely elaborated. I think last question we take. MD full name is not written. When would you ask for micro versus macro prolactin?
When the levels are too high and the symptoms are not there. So why would the levels be too high? That can only be there if they are there's a lot of prolactin. But what if the prolactin which is actually there is actually macro prolactin? And then you call the lab, you get a test done in a different manner. I wish we could have the endocrinologist opinion over that. This is technical.
Yeah. I think he has left with his regards because he was busy in his clinic. So I just had to emergency rope him in, and he was
he was
nice
wonderful.
nice enough to.
He came and he clearly, very vividly,
He's very good in academics.
Yes, just
so
ask the lab to get the macro prolactin levels done separately. So what they'll do is they'll dilute it and they'll do something of the titration, and you actually get a real report which clarifies that prolactin levels are not that raised. It was falsely raised because of the presence of macro prolactin, which is actually the small prolactin bound by IgG.
Okay. So now inviting Dr. Veda for closing remarks, then we can wind up the sessions.
Thank you, sir. Dr. Jagjot, I think you made a very lucid and very informative, elaborate presentation. One of the very common side effects that we all encounter with our patients, especially, they come up with the history of decrease in libido immediately after they have been increased on risperidone from 6 mg to 8 mg, at times even susceptible when they are in low doses of 2 mg to 4 mg as well. So this is a perfect example of consultation liaison, I must say, wherein it requires a teamwork, involves endocrinologists, a psychiatrist, a gynecologist, all three of them to step in. And we should also see that we get the basic prolactin levels done as soon as when we know that we have started patients on high potency drugs. Should not really wait for them to come up with full-fledged symptoms, I must say. Even when they come with the subtle symptoms like decrease in libido or irregular menstrual cycles, one should definitely start evaluating the patient, is what I understand. And like you rightly said, from switching over from high potency to lower potency drugs, especially aripiprazole, which definitely is the drug of choice, in a decent dosage of, let's say, about 5 mg to 15 mg, has shown clinically a great response in most of the patients. And as the endocrinologist even today emphasized that cabazolin in low doses twice a week, given at least for 2 years, definitely should make a lot of difference in improving the quality of life of our patients, those who suffer from these kind of major side effects.
In cases of adenomas, microadenomas for 2 years.
Yes.
Sorry.
Yes.
Not in drug induced.
No.
Thank you, Dr. Veda. So,
Thank you.
Any comments from co-moderators? So Fansar also had to leave because of personal issues. So
I
we
think
have to
it's-
wind up the session.
I think Jagjot very nicely presented. I think very comprehensive, very clear. You think hyperlactemia is a small issue, but I think the way you presented it, it makes a lot of sense to a lot of people. I think a lot of people stuck around. We had around 150 plus participants throughout. So that's very, very good attendance for us. And I think you did a very good job.
Thank you, sir.
Excellent.
Credit goes to Dr. Alim. I mean, he was
for forcing Jagjot to come out with it.
not really. I mean,
Shobit, any word from you?
Sir, I think I shared in the chat box. Very importantly, sir, investigate जब symptoms है तब कराना है. But अगर level बढ़ा हुआ मिल जाए, then clinical discretion is more important. And अगर chronically prolactin बढ़ा हुआ है, vitamin D should be supplementation should be considered because of the risk of bone mineralization, specifically around 50s, 60s. I think wonderful, Jagjot, as usual. Thank you. Thank you.
thank you, sir.
So let me formally thank Jagjot. Jagjot, one of the speakers actually dropped out, so it was an emergency session for which he kindly agreed, and it was such a wonderful session. Matlab, you took us through all the story from the starting to the end. So it was very nice. I think very knowledgeable. People who attended usually will now be more aware of how to manage prolactin, how to look about it. So I think their clinical skills will improve. Thank you, Dr. Vishal, for your inputs. Always keeping the things on time and keeping the background things in check. Thank you, Shobhit. Wonderful addition to the team, bringing a lot of academic inputs, a lot of new ideas. So whenever things are a bit slow, so you are acting now as a catalyst. So you are our new catalyst now. Thank you to Dr. Tofan sir. Tofan sir had to leave because of a personal issue. Amrit is in a flight. He's on to Bangalore. So he had to miss the session. Thank you to all the participants, Odisha State Branch and Torrent Pharma for supporting us. So it was really a time well spent. Thank you all. Thank you.
Thank you.
Closing
Thank
the
you.
session now.
Bye-bye.